All right. So we're talking about modes, particularly the more advanced modes, meaning to say your volume measure pressure support versus ASV. Okay. So what are the difference? When you think about it, the main difference between these two are one, the patient types. Patient types. Why? Patient types, ASD patients are those with central sleep apnea. How about for VAPS? Yes, they can also have central sleep apnea because the algorithm is not too far behind. The difference is that on VAPS, even though they both have a backup rate, and backup rates can help mitigate what? Central apnea. Aside from you can reduce CO2 levels, both can address central apnea because of the backup rate. The difference also is that they can both increase and decrease their pressure support or their IPAP. So in a sense, it has automation to ventilate both. They can ventilate both types of patients that are in ASV and or in VAPS. So backup rate and then IPAP or pressure support, it can change, it can vary. So that's why they have similarities, but they also have differences. Main difference when I mentioned about pressure support is that you can create a target volume, meaning to say on ASV, there's no target volume in a sense that there's no protection as far as what is the minimum volume before the patient is allowed to underbreathe. What is the volume that the ASV is protecting as far as volume is concerned? Nothing. What it does is ASV will study the patient's breathing pattern and it will not protect, but it will allow the patient to fluctuate for about 10%, right? 5 or 10% of their minute ventilation or peak flow. So let's expound on that. ASV is looking at the pattern, whether you're using Philips or ResMed. One will look at minute ventilation, meaning to say respiratory rate and tidal volume. It will look at the patient's own minute ventilation in a 3-minute window. Philips will look at the patient's own peak flow, how high the peak of the respiration is. That's the peak flow, right? But it looks at that on a 4-minute moving window. So moving 3 minutes, Philips moving 4 minutes. Both will allow some fluctuation. We're not robots, so we can breathe in and out deeper and a little bit shallower sometimes, but then it will always average, right? It's not looking at just the breath, it's looking at a moving 3-minute or 4-minute window. It follows the patient's breathing pattern. So if the patient's breathing pattern suddenly drops, either ResMed or Philips will look at a drop in peak flow or minute ventilation. When you turn lights out, it starts from that time to a 3-minute forward. Now the more recent 3-minute or 4-minute window, it will always look for the average minute ventilation or the average peak flow. The minute ventilation niya is, sabihin natin, 8 liters per minute. Okay, meron konting fluctuation na 7.8, then 7.9, minsan lampas ko nga eh. So we take some size, we can sometimes move and then drop in our ventilation or drop in our peak flow, all right? The point is, the device will allow for certain drop, but as soon as you drop further, then the device will move now from a minimum pressure support and it will start to increase its own pressure support to push the patient to reach that minimum allowable drop in minute ventilation or drop in peak flow. Does that make sense? So if you think about it, let's say Jeremy is running a marathon. It's a long run. It's 26.2 miles. So you cannot sprint. It has to be a pace, right? You get me? You follow? So when you're running a pace, let's say that's your minute ventilation. So sometimes you'll slow down, right? Maybe there's a little frog on the road and you stop over and ruin your pace and then you try to get back, okay? But you're still running. Now, ASV will have somebody behind you who is perfect in their pace. So if you start to slow down, this pacer behind you was pushed forward. They maintain their pace. Okay, so it means that if the patient drops in minute ventilation or in peak flow, that push forward is the slow increase in pressure support, where it will start to increase by the machine, not by the patient, so that the patient will maintain their own minute ventilation or peak flow. Does that make sense? If the patient ends up with a central apnea, that big drop in pressure will be a flag for the ASV machine. The device will allow the patient to fluctuate. Right? They will have at least 5 or 10% allowable drop. So if the patient drops below that threshold, the device will start to increase pressure support. The patient usually will not have 10 seconds of central apnea because the device has a backup rate. It will not allow the patient to have a central event because the device backup rate will immediately kick in to ventilate the patient. That's why it's important to understand that the way ASV works is that it will not just give a backup rate with a hard increase in IPAP. It will slowly increase its IPAP. Let's say the IPAP was only at 9 centimeters water pressure. Then on the next breath, it will be 10, right? And next few breaths, it will be 11. So it starts to increase pressure support as the patient is breathing. Why? Because it knows that this patient has a central apnea issue. Central apnea patients, if they are overventilated, you will only prolong their central events. That makes sense? Central apnea patients are very sensitive to increased pressure. Therefore, the ASV is a slow increase in IPAP. Okay? It's a very slow increase. It will not immediately give you a maximum pressure support. It will give you a minimum. They will start to increase after a breath or two, start to increase pressure. Because it's designed to not overventilate the patient because the issue is central apnea. The other thing that I would like for you to read on and watch is high loop gain. So you can fully understand how central apnea occurs and how these types of patients are not well suited for CPAP or bilevel ST because of their high loop gain, particularly heart failure patients. That's why ASV works for them, because ASV, even though ASV has a backup rate, and typically it's at 15 breaths per minute. If you put it on manual mode with Philips, you can dial it down or up. You can increase or decrease that backup rate. But in ResMed, ASV has a dynamic backup rate, but that backup rate is typically at 15 breaths per minute. Any questions on ASV? Please ask questions. If you're not sure, which part should I re-explain? And don't be shy. PWX, when you're talking about ResMed algorithm, it will not wait, not even 1 second. If the patient drops ventilation, the ResMed machine will monitor the minute ventilation. So as soon as that patient stops breathing, a breath will be given immediately. You will not even see a 2-second apnea. It will show immediately as a breath, but you will notice it's a machine-triggered breath. It's not going to be a patient-triggered breath because the patient's having central. So how is the waveform of that breath is more of an ocean wave pattern. It's not a square waveform like all other devices. Okay. So if you're using ResMed to titrate the patient on ASV, you will only set the minimum and maximum pressure support and EPAP. As a tech, you will increase EPAP for what type of events? Yes, obstructive sleep apnea only. Not for snoring, not for desaturation, not for hypopneas. And if you're calling rarest still, not for rarest. You will only increase EPAP if it's an obstructive sleep apnea. Okay? You have to be careful when you're doing ASV titration, simply because ASV patients or truly central apnea patients, whether they have true central apnea from the very beginning or they have complex sleep apnea, Complex sleep apnea are these patients that develop central once they're exposed to CPAP or bilevel. Any positive air pressure, these patients turn into central apnea. You can never find the right setting for these patients in CPAP ASV modes. You will not. They will always either have some more obstructive events. When you increase a little bit of pressure, they turn into central. There's no perfect pressure for that. These are your complex sleep apnea, or otherwise known as TEXA, TEXA. So when you are working with ResMed's VAPS, which is predominantly what's used globally right now because Philips had pulled out most of their machines. But when you work with that, you only set EPAP, the tree increase for obstructive events, and then you set a minimum pressure support and maximum pressure. When you're titrating on ASV, you only increase EPAP as soon as you're seeing obstructed. As soon as you finish addressing all obstructed apneas, you stop increasing EPAP. You never increase EPAP after you eliminate the obstructed apneas. You got it? You now just increase the minimum pressure support. So minimum pressure support is basically your IPAP, right? Because pressure support is any pressure that you add on to your EPAP, which is your basically your IPAP. So if you have an EPAP of 5, you have a pressure support minimum of 3. What is your IPAP? So if your minimum pressure support is 3, and then you have an EPAP of 5, what's your IPAP? You combine it. 8. Okay. Okay. Your EPAP is 4. And then your minimum pressure support is, what is your IPAP? 7. Correct? You just add that. That means your is when you add your pressure support plus your EPAP. That's your IPAP.
We only increase for OSA, the EPAP.
Correct.
Against
everything else is your pressure support minimum or your IPAP. So it's 2, 3, 5, 3. Correct? So you only increase pressure if you see 2 apneas and then 3 hypopneas, 5 rares, and then 3 minutes of unambiguous snoring, meaning to say it's constant snoring, it's real snoring. Then you increase your pressures. But if you don't, then you just wait. The thing with ASV is once you overventilate the patients, you cannot fix it by increasing pressure, whether you keep increasing EPAP or increasing pressure support. And most of the time, ASV pressures, there's a majority of studies that show many of the patients are typically treated around an EPAP of 8 to 12. You don't raise them up. And then the pressure support ventilates them. Okay? So tonight, when you have an ASD patient, look at the patient's profile. If the patient is regular size, maybe 5'7", 5'10", and then 180, 190 pounds, not too big, right? No OHS, if there's no obesity hyperventilation syndrome issues, then okay, you can start at 5. But if the patient is, let's say, 5 foot or 4'11" and really skinny, will you really start your pressure at 5? Even if it's a recommendation from the manufacturer? Or will you lower your pressure? What do you say?
Bring it down.
Sure.
Lower, right? Yes, because you don't want to start at a higher pressure and overventilate your patient. You will never catch up on their central apnea. And so even if the manufacturer says you should start your EPAP at 5, and then minimum pressure support 3, maximum pressure support 15, or even 10. Even if that's the recommendation, you can have your own judgment as a clinician. My patient is tiny. Maybe this patient can immediately react to an IPAP of 8. Maybe that one pressure difference can make a tremendous effect on your titration. So always look at the patient's height and weight. And again, we have been discussing just ASV for about close to 40 minutes. But one major component in ASV titration is for them to have an ejection fraction of better than how many percent? Anybody remember? 45%. Okay, very good. So you cannot do any patients with less than 45% left ventricular ejection fraction. They must have a better heart than that. Otherwise, you can get sued. There's a high mortality rate based on the clinical trial that was done a few years ago when they used ASV with patients that have worse than 45% left ventricular ejection fraction. All right. Now going back into the titration. When you're titrating the patient ASV, the first thing you need to do is to allow the patient to get comfortable. You do not start the ASV and put the mask on. Okay. Remember, what does the ASV algorithm do? It studies the patient's breathing pattern. If you're using ResMed, it will study the patient for a good maybe 40 minutes to an hour. So when you start an ASV titration, you don't immediately put the mask onto the patient. You can let them try it, right? Before you start your study, you can let them breathe with the machine, but you don't start your study immediately, right? What you want to do is to establish the patient's resting respiratory rate. Again, you want to establish the patient's resting respiratory rate. Why? Because when the patient first lay down, their minute ventilation or their peak flow are high. They're still awake, right? They're still very awake. So their minute ventilation or peak flow is high. The device allows for them to have a 5 or 10% drop from that initial peak flow or minute ventilation. So if you start the study, you immediately record and then put the mask on and start your titration. The device understands a high baseline minute ventilation or peak flow. So by the time the patient is just resting, the device can start increasing pressure support when the patient might still be awake. You get my point? It's why? Because as human beings, we always drop our minute ventilation, our pulse, we drop our muscle tone even, right? We drop everything by at least 5, 10, 15%. By the time we sleep, we don't have the same minute ventilation. We don't have the same peak flow. We don't even have the same muscle tone when we fall asleep. Things drop because our metabolism requirement is also less when we're sleeping. Meaning to say, there is a reduction in the person's minute ventilation when they fall asleep. But if you start the device learning this patient's weight, minute ventilation, and heart rate and breath per minute, the device will immediately respond on that high baseline. So the patient might wake up, oh, I don't know, this pressure is already pushing hard and I'm not even asleep yet. So that's why patients complain. You get it?
Yes.
So this is one of the key factors when you're doing ASV titration. This became an ASV talk, right? But I'm just trying to establish ASV before we jump into VAPS. But that's one of the key things in ASV. And you can start ASV on a nasal mask, a full face mask, or even pillows. Make sure you know that because pillows can handle efficiently 18 centimeters of water pressure or even a little higher. I use the pillows mask myself and my ASV auto goes all the way up to 19 centimeters of water pressure. No problem. No leak. Yeah. 19. Yeah. My maximum pressure support is at 8, I think, maximum pressure support. So I go all the way to 19 or even 20. So you got it? When you put the mask on to an ASV patient, make sure that they're already resting. They are relaxed. They're not hyped still. They just came from the bathroom and then they lay down. Let them relax. At least 5 minutes. Just relax for now. And then do your little calibration. But before you hit lights out, make sure that they already have reduced their respiratory rate, and even the tidal volume. You can see all that on your the KTX, right? On that the little graph that you see on your machine on these kits. Any questions? ASV is an
Yeah.
easy titration. Once
Yeah.
you figure it out, because ASV has an automation, so it's
Mm.
less work for you. But what you can do in ASV is that when you start the patient, the starting point should be you let them relax 5 to 10 minutes. Once they're comfortable, like they're starting to get sleepy, that's when you put the mask on. You can even start the patient calmation and then let them just relax for a good 5 minutes, at least 5 minutes. And then check on them. Are you okay? Do you feel like you're getting a little sleepy? Oh, yeah, I'm comfortable now. Okay, then we can start, right? Put the mask on and start your study. The lights up. So now the patient has a resting minute ventilation, resting pulse rate even, and resting breaths per minute. Okay. So now you leave the patient alone for 40 minutes. You will not increase pressure. You will not touch the patient for 40 minutes, 40. Okay. That's the protocol. But if the patient falls asleep and immediately shows obstructive events, increase the pressure by 1 and then wait 5, 10, 15, 20, 30 minutes. If you don't see immediately again 2 apneas, 3 apneas, then increase pressure. But never be aggressive in ASV titration. Never. ASV patients need to be titrated very slowly. Okay. Your biggest point there is to find the right EPAT first. Why? You cannot ventilate the patient with a closed airway. How can you ventilate them with your IPAP or your pressure support when the airway is collapsed? So you need the appropriate EPAP, just enough to keep it open, right? When you have it open, don't increase it anymore. Focus on your pressure support, on your IPAP. If you're using ResMed, you will see minimum and maximum pressure support. If you're using Philips, you will see minimum IPAP, maximum IPAP. But you don't really touch maximum IPAP. It will not do much. You really focus on increasing your EPAP and increasing your minimum pressure support. That's what you need to do. First, you can address your obstructive component with your EPAP. And once that is fixed, you have an open airway. Now you're ventilating the patient. But very carefully, you watch the patient's cyclical pattern by looking at your app clock from a 30-second window. You push it back. You look at the patient from a 5-minute or 10-minute window and look at the SpO2. Check out the SpO2. Is the SpO2 still cyclical pattern? Leave the patient alone. If the patient's SpO2 is starting to improve slowly within the 5 or 10 minute window, don't touch the patient. Okay. Then wait. If you increase the minimum pressure support, wait another 10, 20, 30 minutes, 40 minutes, even to an hour. Why do I say that? Because central apnea patients are very sensitive to any increase in pressure. The worst thing you can do is to over-ventilate a central apnea patient. Once you already over-ventilate the central apnea patient, it's very hard to control. You have to pull pressure back. And it takes a while for them to respond and recover from central component. For example, there's no more obstruction, and now you see desaturations. So now you increase your minimum pressure support, right? Wait 10 minutes, 20 minutes after, you look. If your saturation is slowly improving, let's say it was dropping to 89, 88, 87. Now it's 91, 90, 89, 92, 91, 89. There is an improvement, correct? So if there's an improvement, wait, give it another 10 minutes and then look at it again. Is your saturation now staying within 92, 91, no more drop under 90? Then you are fine. Leave it alone. That's the key. But after 10 minutes, 20 minutes, 30 minutes, your saturation is still dropping below 90%, then increase pressure just by 1. You're almost done. You're almost there. Okay. Then that's a key with ASV. You have to look at it again from into 5-minute or 10-minute window. And you look at the pattern of the SpO2. All right. In the exams, they don't mention brands. It's actually against the rules to mention brands. They won't even say Remedy or Inspire. They'll say hypoglossal nerve stimulation versus phrenic nerve stimulation. They won't say brands. They will give you a question that only shows the pressures, right? They'll say, let's say number 35 questions. What mode is this with a prescription of EPAP 10, minimum pressure support 5, maximum pressure support 15. So that's the question. Then your options are bi-level ASV or VAPS. So when you have just 3 settings, EPAP, minimum pressure support, maximum pressure support, or EPAP, minimum IPAP, maximum IPAP, that can only be what? ASV, right? You got it? The other question is they will say the mode. During your ASV titration, they'll give you a scenario. You have titrated the patient up to a pressure of EPAP 8, minimum pressure support 4, maximum pressure support 12 or 15, whatever, right? Now, after 10 minutes, the patient is in RAM. Now the patient is showing some desaturation. What is your next step? So with that said, what are you going to do? I mentioned earlier, if the event is obstructive in nature, you increase that. But this case scenario, your issue is what? Desaturation. Right? So what will you increase? Yes, minimum pressure support or minimum. Yes, it's the same. You just add your pressure support with your EPAP, and that's your minimum IPAP. You add your EPAP plus your maximum pressure support, that's your IPAP. Nice. Right. Okay. Is that clear? Now, other questions. I'm glad you asked that question because one of the questions that they can give you is that you have this type of patient. What mode is most applicable to this patient? Right? So if they say, what is best mode for this patient with a history of severe sleep apnea and not presenting central apnea after being placed on CPAP or bi-level, what's your answer? So the case is, what is the most appropriate step when you have a patient on CPAP and was diagnosed with severe sleep apnea? After 2-3 months of being on CPAP, now the patient is presenting central apneas. What is the best mode for this patient? That's a loaded question, right? You can use BiPAP or bi-level ST because ST is a backup rate. It will address central. However, if the patient is truly a COMPSA, right? COMPSA is the same thing as ECSA. If this patient is a complex sleep apnea or a treatment emergent central sleep apnea, TEXA, patient, that patient will not do better on bi-level ST because bi-level ST offers a fixed, and they will always overshoot. Meaning to say, if it's a real COMPSA or TEXA patient or a real central apnea patients having more than 50% of their events in central component, they will just exacerbate the central if you put them on bi-level ST. Okay? Because it's a constant pressure support. Any patient with real central apnea issue requires a dynamic pressure support. Whereas if they start to breathe, the pressure support should minimize so that it will only be their own volume. It will only be their own breathing pattern. If the patient now starts to breathe, then the device will start to ventilate them with that increasing volume, increasing pressure support. So they're not overventilated. Because if you're using a bi-level or BiPAP ST, giving a constant backup rate, and your patient now has taken a breath, and here's your backup rate, you just added more volume to that patient's breathing pattern. So you overventilate the patient every time. It's a constant pressures. Okay? Instead of just a little push to increase their volume, it's a big push because it's a constant volume of pressure support on bi-level ST. So the answer is then if the patient has a real COPSA or TEXA diagnosis or true central sleep apnea, they will do better with ASV modes. Actually, if the pulmonologist is careful, there will even bi-level ST will not be given to that patient. What they will do is during a titration, when you put a COPSA or TEXA patient in a titration, usually you will always start with a CPAP and then you switch to bi-level. And then when the patient has central, even from the CPAP titration, you switch it to bi-level, still having central, you switch it to bi-level ST with a backup rate, still having central. In fact, the central will become worse. So then you want to switch that to ASV, but then you cannot immediately implement that because you need the patient's LVEF result. If you don't have that on hand, you go back to the lowest possible pressure before the patient converts the events into central. So that pressure is the non-central toxic pressure, basically. Let's say, for instance, and I'm going to just write this whole to clarify, and then we're done. For example, your patient's name is Jeremy, and Rowan was doing titration. And this patient was ordered a split night. So Jeremy was there for split night. Rowan did her thing. She did the 2-hour total sleep time. And within those 2 hours, Jeremy had severe apnea. So Rowan started the split night, the treatment portion with a nasal mask, and then put the patient on CPAP. As she increases pressure, she's now at 10 centimeters of water pressure because of Jeremy's obstructed apneas. Now, after 10 centimeters of water pressure, Jeremy still continued to have obstructed events. So what will Rowan do is decrease CPAP again to 11 centimeters of water pressure. But when Rowan increased it to 11, Jeremy's events now turn from obstructive apneas into central apneas. And when Rowan increased further in pressure, the central apneas just became longer in duration. Then she switches to bi-level. 8/4. Starts to increase pressure, central apneas start to increase and became longer and longer. She now switches and turns on ST mode. Same thing happens. The central is exacerbated further. What Rowan will do is to go back to that pressure and mode before the events became central. So now she has to go back to the non-toxic pressure of 10 water pressure on CPAP. Because when she switched 11 centimeters water pressure, the obstructive events turned into central. You get my flow? Does that make sense? It's a lot to explain, but when you're actually doing the ASV, it's very easy.
Yeah, I know.
And slow titration. All right. So any more questions? Okay. For all of you, take notes. Other than that, thank you.